Dennis Wogan. I'm the founder and director of the Clear Scoliosis Institute, and today we're going to talk about how to make an adjustment actually work better. Too often in chiropractic we get the patient in, they've been sitting in the reception area waiting and waiting, they come in, they lay down on the table, they get cracked and they get sent on their way. And 20 minutes later they go, well, that felt really good, but I actually feel like I need another adjustment right now. What we found, especially with the Clear protocols, is that we want to go through procedures where we go through mix, fix, and set. With every patient, what we want to do is loosen that spine up to begin with, and then we want to go ahead and fix it in position with the adjustment, and then we want to make it set to stay there. So we're going to look at today some of these protocols we're going to utilize to be able to do that. So now we're going to take a look at the mix, fix, set procedures. Quite a few years ago I broke a piece of plastic and I decided that I needed to be able to fix that plastic. So the first thing I did is I went into my garage and I took epoxy glue and I mixed the epoxy glue together. So this is the mixing, getting things into position. And then the next thing that I did is that I went ahead and put the glue on the ends of the pieces that were broken, and then I fixed it into position. Now the fix is actually the chiropractic adjustment, and the better the adjustment, the better the alignment's going to be, the better it's going to be fixed into position. But the problem is that if we don't let it set and stay glued, it's not going to stay in position. So the adjustment is real important, but afterwards we have to come up with a way to make it set in that place. So just like the glue has to have time to dry, we've got to make sure that the adjustment has time to stay in place. We want to make sure the patient holds their adjustment for as long as possible. We want it to be subluxation free so the body can heal itself from above down, inside out. So the fixing after the adjustment is really important. When we go ahead and we look at what we're going to be talking about, with the mixing we're going to be actually utilizing a wobble chair to get the patient warmed up, or an active rehab chair. We're going to go ahead and do a core stim on some of the muscles that are tight, get that spine loosened up. Just like in Minnesota, we're not going to go outside when it's 30 degrees below zero and start the car and take off. We're going to let the engine warm up first. Then after we do the mixing, then we're going to look at some very precise cervical adjusting. And it's not just a matter of cracking the neck. We want to make sure that we do corrective chiropractic care so that the before and after x-rays show an improvement. After we've done that adjustment, very specific and spinal adjustments, full spine adjustments, we want to be sure that we can go ahead and make sure that it's going to set and stay in position, and that's the protocols for mix, fix, and set. We started to talk about the mix protocols. When the patient comes in, we're going to have them sit on this active rehab chair and move him around back and forth, front and back. Come on, move it, good. And at the same time, she's also using the head weight and the glasses, which is going to keep the head in a proper perspective. Now, after the age of puberty, the blood supply that goes to the disc atrophies and disappears. What the blood supply does is it's actually going to feed the disc, and it also cleanses the disc. So after puberty, there's nothing that's going to feed or cleanse the disc, so then we start to see disc degeneration. Fortunately, after puberty, the body's not completely done at that point, but it's going to rely upon imbibition and osmosis, and those processes involve motion. Most people don't get enough motion, so what the active rehab chair is going to do is get motion into the spine. It's going to create motion, which creates friction. Friction is going to create heat, and it's going to change the hydrogel disc into a hydrosol state, thereby mixing the spine and preparing it for the adjustment. Part of the additional stuff we're going to do with the mixed protocols, the examination, we found some muscle tension on this patient, especially where it's really tight. What we want to do is get those muscles to relax. So we're going to use a core stim to do that. This is actually a modified Makita jigsaw. We've worked with the Makita Corporation. It has to be at exactly 270 RPMs when it goes slow, and around 38,000 RPMs when we go fast. So once I find these areas where the muscles are tight, we're going to work on that area. The neat thing about this, the core stim, is that it has up and down motion, which is called linear vibration or tapomation. A lot of vibrators are orbital, but the linear vibration is 68% deeper. So we're just going to work those areas, a type of trigger point therapy, until we feel that those muscles are relaxing. And any place else where we feel tense or tight muscles, we're just going to work in that area as well. Usually about 60 seconds in that area, because what this is going to do is it's going to get rid of a lot of the waste products as far as the muscles go. So we also want to encourage the patient to be able to drink a lot of water. There's other mixing protocols which we use a lot with scoliosis patients, but we use this part on all of our patients. Now when it comes to the set protocols, that's the adjusting part that we want to be able to do. And we do the full spine adjusting. We base it on the neurological leg check, which has to do with the spinocerebellar tracts to tell if there's an upper cervical subluxation. We're going to go ahead and do an anterior dorsal adjustment. We're going to have the patient turn their head away from their high shoulder, turn your head to the left, and just go in with the shaft of the ribs. Very easy. Anterior to posterior line of drive. And then we're going to have a rollover on the right side here. Based upon her x-rays, she's got an acute lumbosacral angle on this side with the posterior hip. Now all these adjustments are based upon x-rays. Now I'll go ahead and sit up here. Quite a few years ago I bought a digital motion x-ray machine, and as I started to evaluate patients with that digital motion x-ray machine, I started to realize that probably 99% of our patients have some type of ligament instability. So if we start taking these patients' necks and cracking them one way and cracking them the other, all we're really doing there is manipulating fixations and causing additional ligament instability. So I use primarily the arthrostim when it comes to cervical adjusting, and I haven't done any cervical adjusting since 2009. So with the arthrostim, I like it. The normal body responds at 333 milliseconds, and the arthrostim fires at 167 milliseconds. So in other words, it's just subneurological threshold. For example, I can tap her and she's going to come back, but if I tap, 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 I win. So with the arthrostim, again, based upon the x-rays, we're going to adjust the occiput, atlas, and the P to A adjusting on that cervical spine. This is going to help the adjusting to restore that cervical lordosis. Again, because it's at 167 milliseconds, it's faster than the osteological areas of the body can respond, including the tendons, muscles, and ligaments. We can follow that with adjusting to cervical dorsal angles with C2 spinous, especially with the atlas, especially if there's a neurological short leg. And then also P to A adjusting on C2, and then some videos of this online. And that C2 P to A S to I line of drive really helps as far as restoring that cervical lordosis. Now lie down again. And the post adjustment is always followed by the leg check again. And the balance is good, but now I want to go ahead and make sure that we set this whole thing into position with spinal weighting and whole body vibration therapy. Hi, I'm Dr. Dennis Wogan. We're going to look at some spinal weighting and some neuromuscular education. This is our helper, Teresa. First thing I want to do is take a look at how to start changing the head posture, specifically the relationship of the occiput to the atlas. Now, if I have a superior occiput and a superior atlas, if I put a head weight on the front of that, the cantilever effect is going to make that worse. So with a superior occiput and a superior atlas, what I want to do is the therapy glasses, and the glasses have tape on the top one half. So when the patient puts these on, in order to see, they have to bring their head into extension and hold it. Holding this in position as they look at the horizon is actually caused the mechanoreceptors of the joints of Luschka in the spine to change, and through neuromuscular education start to hold it into position. So at home they need to do this for around 15 to 20 minutes. So we're going to have Teresa put those on. Okay, and then by standing on the vibe at the same time, we get the whole body vibration therapy. You're going to just face me. So the 30 hertz of the vibration activates the mechanoreceptors and also stimulates the tendon, which is the Golgi tendon organ between the muscle and the bone, to hold it into position for retraining. So what we're doing here, when we've got a superior occiput and a superior atlas, by bringing that chin into elevation, it brings both the occiput and atlas into position, improves the cervical lordosis, and also reduces the forward head posture. So the glasses are going to come in very handy if we have a superior occiput or a superior atlas, or a combination of both of them. The other thing that we want to look at is any time that we have what would be a flexion malposition of the occiput, where the atlas is actually going superior, which means the posterior arch has gone inferior. The only way we're going to change that is by utilizing the glasses to bring that chin up. So with an inferior atlas, we always want to go with the superior. When you get a convergence and flexion of the occiput and the atlas, we want to go with the glasses. The next possibility that we have is utilizing head weights. Where's that? This is the new halo posture head weight, and all the weight is directed in front. Now, go ahead and put that on. Once you put the head weight on, automatically what this is going to do is make the extension muscles of the spine kick in. So she's going to go a little bit into extension. And then because the eyes are the basic righting reflex of the body, as she looks straight ahead forward, okay, to see where she's going, it's going to bring the chin down and decrease the forward head posture. So this is looking at from more of a neuromuscular point of view, where the glasses is more of the neuroplasticity or brain remapping that we're doing together. Now, we'd actually do this anytime we have a extension of the occiput, an inferior occiput and inferior atlas at the same time, resulting in forward head posture. So when we don't have a superior occiput, superior atlas, this is what we're going to be utilizing most of the time, and then she's going to stand on the vibe there. And again, the vibration therapy, 5 minutes on here is equal to 15 minutes of doing it at home, because it takes 15 minutes to do proprioceptive nerve muscle education. Smile. So there's times when we're using the head weight, and that's not quite enough alone to do it, so we actually do the therapy glasses and the head weight together. By doing this, we're actually involving the eyes a lot more, but it's a limited vision as far as field goes, so she has to go into more extension. Then we've got the head weight also working the muscles at the same time. It's also possible to take a stress x-ray with the weight on as well. Here we've got the head weight. You can see the patient's looking straight forward into the mirror so that their ocular orbits, the eyes, are going exactly straight in front. With the stress x-ray, we can figure out what areas aren't responding the way that we want it to, and then adjust those areas accordingly. So what we're seeing here is a lordotic S-curves, frontward and backwards. With the head weight on, we can see how the lordosis starts to come back in. There's also a decrease in the gravitational weight line. What we'll often frequently do is do a stress x-ray, an x-ray without the glasses, a lateral cervical neutral x-ray to begin with, and then take an x-ray with the glasses on or the head weight on to see what it's doing. Now sometimes when we put the glasses on, we'll take a stress x-ray, there's no change. And what will happen here, instead of the head coming back here, should pivot in this area here. So it doesn't really change as far as the lordosis of the neck. She's reacting down here. What that means is we've got a front force, but we need a counter force just below that force to change it. So then what we'll do is put a backpack on. And any backpack, and this is a camel pack, keeping the weight up high. So what we've got here now is the P to A force in the thoracic area, the counter force here. And what that's going to do, if we're not seeing the change, it allows that whole thing to switch around. If we're seeing that at home, they could actually do the same thing sitting down in a chair with a back support in the middle back, so that we've got an opposing and a resisting force in there. Okay, now let's set this off. The next scenario that's going to happen is with the head weight and the glasses on, is even though she puts them on, instead of getting the reaction down here, the lumbodorsal area is completely stuck. It's not going to move. So we're not seeing any changes on the lateral cervical x-ray, the stress x-ray, or the spine at all. What we've got to do here is get another anterior force on here to get the whole body to react. So then we'll go ahead with an anterior chest weight. Okay, put your head through there. With the weight here, and then what this weight does is holds the lordosis in place, but this is going to force that lumbodorsal junction to change, and then the head weight in the glasses is going to force the cervical lordosis to change at the same time. The other thing that we can do is just with the anterior chest weight alone, we can go with either 5 pounds for a smaller person, 8 pounds for the average person, and for someone over 200 pounds, we can go like 10 pounds in front. We want a small amount of stimulation to get the body to react. So by putting the chest weight here with the cervical support, what this will actually do is start to bring that lordosis in and line the entire body up to gravity. As a matter of fact, when I get up in the morning, this is one of the very first things I do. When we get up in the morning, what happens is that the Golgi tendon organs are going to set us to our environment immediately. Human beings adapt in time and need to their environment. But let's face it, the average person gets up in the morning, they go into the bathroom, they go brush their teeth, and they start the day like this. Then they wonder why they're not standing up straight. So the thing is, as soon as a person gets up in the morning, if they can even just assume good posture and hold that, it takes 45 seconds for the Golgi tendon organs to quit firing and hold it in that position. So if we have them do this for 60 seconds immediately, or for example, I'll get in the morning, do my exercises and get on this right away and get on the body for 60 seconds, and it'll set my posture for the entire day. And it'll hold it there all day long. Now what we want to do is get the body to react. So here we've got a right high shoulder and a left low shoulder, and this has frustrated me one day. And had a scoliosis patient I've been working on, I couldn't figure out how to get those shoulders to come around. So all I did was took a little hacky sack ball, stuck it underneath her left armpit, and had them hold it like that, and then put them on the vibrating platform, and then I call that the pit ball. See, armpit ball.
Yeah.
So we'll put the pit ball on the low shoulder side, have them hold that there for either 5 minutes on the vibe or 15 minutes at home. They can do this with the head weight at the same time. It's going to activate the muscles as well as the mechanoreceptors, the Golgi tendon organs, to start holding that in position as well.
The head weight would be?
Now we can go ahead and do this with the head weight at the same time. So we're bringing that low shoulder up by utilizing the pit ball, head weight at the same time. And then they can do this at home as long as they're walking around straight and keeping looking straight ahead, or even sitting looking straight ahead. The thing is, they can't do this and looking down at the same time. Now the another thing that we can do here is we've got the head weight in the front, which is going to help bring that cervical lordosis back in. Once we get that lordosis back in, then we can look at doing some side head weighting. So if she had slip this off here. If she was tilting to the right side, what I want to do is put a weight on that right side to get her to tilt to the opposite side. So put this on just the side like we would do a regular head weight.
So if the right ear was low,
Right, but turn the weight over here.
you'd put it on the low side.
Yeah. Okay, right there. Is that going to stay?
Yeah.
Basically what we're looking at here now, if she had just right head tilt, by putting the weight on the right side, the body's going to react away from that.
Got it.
Remembering that the body's going to pivot around the center mass of skull. So what this is going to do is cause a rotation of the head itself. So it's going to be more of a rotational aspect. Now if I want to get a translational aspect, let's say it has to do with more of a right head translation, which
Right.
is tilted off to the right side. All I have to do is bring the head weight down lower diagonally, like this, so it's below that center mass of skull. So what that will do then, it's going to translate that head from the right to the left
Oh.
side, where if it's above, it's going to rotate the head. So for head tilt, I would use it above the center of mass, like we first did it. For translation, what I'll do is do it diagonally to get the head to shift over the opposite way.
Okay, got it.
Going back again, we start just going back to the high shoulder. So she's got a right high shoulder. We mentioned that we do is a pit ball on the opposite side here to elevate it. And looking at it from her back, normally that's going to be like a right cervical dorsal angle, because when the cervical dorsal spine goes off to the right side, that's going to become the high shoulder here. Now that isn't always the case. If we're not seeing a lot of changes here, a lot of times what happens is we can actually see from a spine like this, because I've got a right lumbodorsal angle, because the body's pivoting down here, my high shoulder is coming from the lumbodorsal spine, not from the cervical dorsal spine. So we've got to differentiate where it's coming from. Are we seeing the motion when she's bending coming from here, or are we seeing the motion coming from this area here? So if it's the upper area here with the cervical dorsal area, then we're going to go ahead with the pit ball. If it's coming from the lumbodorsal angle here, what we've got to do is get that body to react. And what we're going to do here is just go with the shoulder weight. I spent a lot of time at airports watching people walking around airports, and when they're carrying their bags, they're not walking down the airport like this, they're reacting the opposite way. And our whole goal is to get that body to react, okay, not to force it into position, but to get it to react into position. So if she's got a left low shoulder here, because she's got a right lumbodorsal area, by putting the weight on that left shoulder, it's going to cause it to react to the right side. Now we can also have her do this with the head weight, diagonal head weight, pit ball, and the shoulder weight at the same time. We're getting that to react. And especially when they're this at home, we want them walking around while they're doing it, okay? Or else on the vibrating platform. Just standing to this, if they're not on the platform, isn't going to make that much of a difference. So we want that motion in there. But you have a lot of people that come in with acute lower back pain, where they're all off to one side. Putting that shoulder weight on causes them to react back to the proper position, and it'll actually decrease the inflammation. It's also possible to use a grid so we can see the patient exactly where they're at. I'm going to have her close her eyes, turn the head to the left, right, center, and keep the eyes closed. And we can use the grid lines to be able to evaluate. What we also have here is a mirror at a 45-degree angle so we can see this three-dimensionally from the top down. Now you can open your eyes, turn to your left, and then we start to go ahead with the spinal weighting. We can see how the body is going to respond to that and take pictures. Now I'll turn to your left again. And now let's just put the weight on this side here. As the body reacts to that, we can compare the lines in the grid as well to see if we're accomplishing what we want to do. One thing that's really helpful with patients is utilizing a plumb line. We center it in the middle of the buttocks and go straight up with it. Then we can start seeing if there's a high shoulder, low shoulder, high hip, left hip. And now turn towards me. You can actually look at it from the side as well, going from the center of the glabella and then looking at forward head posture. So now we're looking at it, we've got a right shoulder weight on. That's going to raise the right shoulder up higher. And we can do this with the gravitational weight line again, the plumb line, to see exactly how the body is responding. This should affect primarily the lumbodorsal area of the spine. We're also going to look at doing some hip weighting as well. And the idea is by putting a hip on the front of or weight on the front of the hip, it's going to cause that hip to go backwards. It's going to react. And if I put a weight on the back of the hip, it's going to cause that to go forwards. So if I've got a posterior PI hip, I want to put the weight on the back. If I've got an anterior or an AS hip, I want to put the weight on the front. So in this scenario here, I've got a high hip on the right side, which is anterior, low hip on the left side. I'm going to put we'll pretty much start with like a 5-pound weight for the average person her size. Right anterior, turn around a little bit, keep turning. Left posterior, action and reaction again. So we're getting opposing forces there. Just wearing a hip weight on one side isn't going to do it because we need that action and reaction again. And then at home, she can do this walking around, or we can do it on the vibrating platform. Of course, sitting is not going to do any good at all necessarily. And then we can combine this again with the head weight, the pit ball. We can actually even do a shoulder weight with this, any of the types of spinal weighting to make the body react in time and needs to its environment. Another area that we want to look at is using a front or anterior hip weight to increase the lumbar lordosis. Now the lumbar lordosis will depend upon Ferguson's angle or the sacral baseline. So when we look at the sacral baseline, in a standing x-ray, it should be about a minus 41 degrees plus or minus 5. In a sitting x-ray, it will be 31 degrees plus or minus 5. So if we have a loss of lumbar lordosis that is usually associated with a high sacral baseline, by putting the weight on the front, what this is going to do is allow the body to react to lower the sacral baseline. When we lower the sacral baseline, we're going to increase that lumbar curve and improve the lumbar lordosis. In the same way that we're doing this, it's also going to help as far as holding an L5 retrolisthesis into position. As we increase the lumbar lordosis, there's going to be a less shearing effect on L5, pushing it backwards and posterior. The next thing we can do is if there is a hyperlordosis, too much curve, we're just going to take the weight, swing it around, and put it on the back. By putting the weight in the back, what this is going to do now is actually decrease that Ferguson's angle or sacral baseline. So the body's going to react here to decrease the hyperlordosis to start to restore that normal lumbar curve. And this also works for, say, an L5 spondylolisthesis. So front weight is going to increase the curve, back weight is going to decrease the curve, all by affecting Ferguson's angle. One of the other things that we're going to look at with spinal weighting is doing a type of translation. This is called an SLA, or a shoulder lever arm. I'm going to have you turn around. We can use this with other weights. But as you see here, we do a gravitational weight line coming straight up. We can see how it translates and shifts the body from the right over to the left side. And then, depending upon the patient, we can actually add additional weights as we need to. And that's going to get them to actually move even more. We just got to be careful not to overload it. But all of this stuff is explained in some of the advanced seminars. In conclusion, as we go through and look at the mix, fix, set protocols, we find this works really well as far as loosening the spine up so the adjustment goes better, putting the spine back into the normal position, and then setting it to make it stay there. By doing this, chiropractors become the spinal experts and the adjustments hold a lot longer. I'd also like to direct you to the website here at the Clear Institute. If we go into seminars, you can see there's some videos here. One is restoring the cervical lordosis. This is a over 2-hour video that explains how to do that. Also here we have adjusting with the arthrostim, the cervical adjusting. This is in English and Spanish as well. And that'll give you a better idea how we work all the procedures. If we go into the videos in the doctor's section, what we're seeing here is a X-ray analysis video. Gabriel's video is a complete video about about scoliosis patient. So it goes through a lot of the adjusting procedures here as well. And at the bottom here of the seminar shows where you can take the seminars either online or in Dallas, Texas at Parker University. Thanks for your time.